Hello, everyone. My name is Ann Ashenbrow. I'm the Associate Chair of the Epidemiology Department, and I want to welcome you today to our department-sponsored Public Health Forum. As many of you know, the influenza pandemic of 1918 is considered one of the greatest medical holocausts in human history because it killed from 40 to 100 million people. Most experts agree on two things today. First, that there will be another influenza pandemic, and second, that nobody can predict when it will occur. Do you want to read now? We are fortunate to have Marc Lipsitch with us as our guest speaker. He is one of the experts that has been studying influenza pandemic. He's a professor of epidemiology and in the departments of epidemiology and immunology and infectious disease at the other School of Public Health. And his research focuses on transmission dynamics and population biology of infectious diseases and compares in vivo experimental studies with statistical and mathematical modeling. And so Dr. Lipsitch will discuss the lessons we have learned from the past pandemics and our preparations for the future one. And he will speak for about close to an hour, and then our own Dave Osnoff will provide some comments afterwards.
Thank you very much, Anne, and thanks for the invitation. I really like being clapped for before I talk. That gets me off the hook. I'm not usually one for fancy logos, but I'm required to put this on by my funding agency, and not only for visual balance, but also this is here because people point out that it's ironic to have the word veritas there in a talk about mathematical modeling, but I'll let you judge for yourself. I'm going to start by talking a little bit about pandemic flu in general. Many of you will know parts of this, and I won't dwell on much of it, but to try to set the stage, and then talk a little bit.
Switch there for the lights if you want.
Oh, that would be good.
Yeah. Yeah. There.
And then I'll talk a little bit in the second half about my own work and some of the answers, or at least questions, and hopefully answers that it provides to some of the issues about planning for the next pandemic. So, the first question, which Anne has already given you some of the answer to, is why worry about a flu pandemic? And briefly, it's because even normal flu is something we all think of as kind of a bad cold until we have it, at which point we often end up on our backs for several days and very much more unhappy than with a bad cold. And if we're between the ages of about 2 and 65, we are very unlikely to die from it in a normal year. But if we are not, or if we have certain specific conditions, we are at some risk of dying, and the burden of deaths, even in a normal year, is estimated in the 30 or 40,000 range. Interestingly, there have been a lot of methods used to make this estimate. Most of them have identifiably wrong assumptions, and they all come to the same number. So it tells you something about something. I'm not sure what it tells you.
Stick together.
That's right. Pandemic flu, on the other hand, in contrast to normal annual flu, occurs when one of the over 100 subtypes of influenza A, which circulate in birds, is passed either from birds directly to people or birds through an intermediate host, possibly a pig, to people. And the reason for this intermediate host, and the reason why this event is rare for a novel strain to come into people and take off, is that the strains in birds are adapted to birds. They're adapted to bird cellular receptors. They're adapted to transmission in birds. And it takes specific genetic changes, some of which we understand and some of which we don't, for a strain that is adapted to spread in birds to become adapted to spread in people. And sometimes that takes the import of an entire genetic segment or two from a human virus, and sometimes, as it appears to have happened in 1918, it may happen through just the accumulation of mutations, genetic mutations. But the point is, it's novel, so we don't have immunity to it. It's the two major surface proteins that we make immunity to, at least one of them has to change to make a pandemic, and it's novel, and it has to become adapted to spread in people, and that's what a pandemic is. This gives you a sense of the magnitude of the worst pandemic in our history, which Anne mentioned, the 1918, and I think actually the surrounding picture is as interesting as the spike, this decline in infectious disease-related deaths in the United States prior to the advent of vaccinations and antibiotics, which is another story which I find very interesting but won't talk about. But you can see that we went back to pre-20th century levels of mortality for a year and of infectious disease mortality for a year, and then it went away. That was by far the worst. The estimates are between 20 and 100 million from deaths worldwide from the 1918 flu. The subsequent pandemics in 57 and 68 were not nearly so severe worldwide, and certainly not so severe in the United States. And the reasons for that are just beginning to come out biologically. This was a complete change. Both the surface proteins changed, and so there was no a priori reason why it couldn't be as severe, but it was not. This one was probably less severe in part because the neuraminidase, the N gene, didn't change or changed modestly, whereas only the hemagglutinin changed, so there may have been some existing immunity. One of the things that's striking, though, although the numbers aren't necessarily much bigger in a pandemic, they may be, but they aren't necessarily, is that pandemics kill a different group of people. And in particular, they don't only concentrate mortality in the elderly and the very young. So this is the proportion of pneumonia and influenza deaths among persons less than 65. In the 1918 pandemic, it was almost 100%. There weren't that many people over 65 to die. But in particular, it hit younger age groups. And you can see that came down quite dramatically in the subsequent years. Another peak, although less dramatic, in 1957 and in 1968. And interestingly, that persists for a few years, at least in some cases, and no one really understands why. It's not just that it's high and then it goes low. It's high and then it slowly becomes low, and that's a mystery. This is a perhaps more dramatic way to put it from Men's Health, one of my major journals that I read. And Greg Poland, who's an expert at the Mayo Clinic, says people basically, and particularly your readership, are highly likely to become infected and develop complications, possibly even die, because they have arguably the most vigorous immune systems at all. Readers of Men's Health, you heard it here first. The current concern, though, of course, is amplified and is probably almost completely due to the appearance of H5N1 influenza in birds, a subtype that's been around for a long time, but a particularly high pathogenicity variant that is very harmful to certain bird species, has now spread to what appears to be an unprecedented extent. We don't really know the extent of past spread of avian flu strains, at least in the distant past. But certainly since people have been looking in the last couple of decades, this is an unprecedented spread, and you can see that it's throughout much of Asia, some of Europe, and some of Africa. This is as of a few weeks ago. These are bird cases, and of course, we've all heard about the levels of contact between birds and humans. It's estimated that in China, for example, 70% of the 14 billion or so chickens that are alive in China at any one time, about 70% of those are in relatively small holdings, backyards or slightly larger than backyards, where the contact with people is more frequent. So that factory farms, although they are certainly not free of any biological risks, have the advantage that they are under surveillance, and the economies of scale allow them to watch for infection in a way that smaller flocks can't, and those smaller flocks also have more human to bird contact. And as a result, mostly of such contact, there have been now 330 human cases, of which about two-thirds have died, almost two-thirds have died, of H5N1 infection. Again, mostly concentrated in Asia with a few elsewhere. So that's raised everyone's concern about at least the severity of a pandemic. A very interesting question, which I hope maybe we'll discuss a little when David comes up, is whether this actually puts us at a higher risk of a pandemic now than we've been in the past. It looks like this widespread severe disease in birds should be putting us at higher risk. And I think formally trying to estimate that risk is difficult, but maybe we'll have some interesting discussion about that. At a minimum, it tells us that if this strain that's around becomes a pandemic strain, it's one we should worry about, because this kind of case fatality rate is not something that we would like to see in something that could spread in humans. I got interested in this mostly as a result of having worked a little bit in SARS, and before getting on to talk about some research work on flu, I just want to mention SARS as a precedent, which in many ways we think of, it was first mistaken for being a flu strain, among other things, and certainly the response to SARS is in some sense a precedent for how the world might respond to a pandemic of avian flu turned human flu or something else. In SARS, the first known human case happened in mid-November of 2002. The first reports got out to most of the world around February. The global alert happened about a month later, and the whole thing was basically over by the summer, with about 8,000, a little over 8,000 cases and about 10% of those dying. I called this a deceptive precedent on my slide because this was, in some sense, really an easy dress rehearsal. It was not easy for the people doing it, and I obviously don't mean that critically of those people or to minimize what they did. It was a lot of work and a heroic effort to stop this disease. But we could not have asked, in some sense, for a better disease to have to stop. It was relatively low transmissible. Had relatively low transmissibility on the same order as flu, as I'll show you in a couple of minutes. It was very much localized to hospitals to a large degree, although not only, and for other reasons, which I'll show you in a second. Probably the most important thing about SARS that made it possible to control, really by old-fashioned public health means of isolation and quarantine, is that this was a disease where people, if they weren't sick, they weren't infectious. There's no documented evidence out of 8,000 cases out of 8,000 symptomatic cases, there's no evidence of someone becoming infected, having no symptoms and transmitting. There is some evidence that we've just published that severity of disease correlated between people, correlated with infectiousness. But most importantly, the amount of virus you shed was low at the time of symptom onset. This is data from a group in Hong Kong. It was low at the time of symptom onset, although, well, it's presumed low at the time of symptom onset, wasn't measured. It was lower 5 days after symptom onset than 10 days after, and then came down again. And that means that public health measures had, in some sense, 5 or 6 or 7 days to get their act together, to find these people who had been infected and isolate them. And that meant that the process of quarantining possibly exposed people, which also takes several days, and watching them was feasible to do, watching them to see if they become infectious and infected, was possible to do on a time scale that's okay, that's at least practical for some public health systems. It's not easy, but it's practical. This is the paper I just referred to, paper by Jenny Pitzer, who just defended her thesis and just finished, looking at the estimated infectiousness of individuals to their contacts as a function of time since infection. And what we see is, again, around 10 days, a peak of infectiousness. This is in households, a peak of infectiousness, perhaps related to, perhaps corresponding to this peak of viral shedding. This early peak seems to be real in all the ways we've tried to look at it, and is so far unexplained. But this peak is the larger one, and so isolating people at this point in their infection was a very useful thing to do, because the major transmission was later in infection. So overall, SARS was easier to deal with than flu because there's more time to act, there's a delay between infection and infectiousness. And I actually don't have a slide in this set of the timing for flu, but roughly people are most infectious probably between 2 and 3 days after they become exposed. So instead of 10 days or 8 days or so, you have a time window of about 2 or 3 days. For flu as well, people are infectious sometimes before they're very sick. They may be sick already, but they're not necessarily diagnosable with severe or with flu as opposed to something else just starting. So SARS was easier in that respect, and as a result, isolation and quarantine worked well. These old-fashioned public health measures that depend on knowing who's infectious. And hospital transmission being a major route added to that ability to figure out who was infectious and contain them. So I said that isolation and quarantine are not as easy to do for flu, and if you look at pandemic plans around the world, although they're both of those measures are considered and are probably worth trying for flu, it's not that they're useless, they're just less effective than for SARS. Nevertheless, they are not the centerpiece of anybody's pandemic planning. So what can we do? Well, there's a whole hierarchy, and you can think of the hierarchy in a few ways. You can think of it as sort of stages along the path from unpleasant bird problem that leaks into a few people all the way up to full-fledged pandemic. So I'll talk about it in that respect. And you should also think about measures that are permanent solutions versus temporary solutions, meaning things that can buy us time, but measures that once released will no longer be effective, such as social distancing, closing schools, and that sort of thing, versus permanent solutions, which I would argue the only one is vaccination. So keep those distinctions in mind as I talk about these. So the first step is that people would like to prevent transmission of avian strains to humans, which is important but hard, mainly because of the incentive problems in many of the countries where the greatest amount of contact between birds and humans occurs. The money is not there to compensate farmers for the cost of giving up not only the infected chicken, but also the ability to grow chickens for some period of time while the premises hopefully lose any residues of virus. And also ignorance. Certainly when I was in China a couple of years ago talking to people from WHO, there was a broad feeling that the veterinarians, the public health people in the rural areas where many of these chickens are kept simply aren't aware of the problem, even, and that was kind of at the height of the hype about bird flu. The next step, which some people have pushed for very hard, is the notion that if there were a pandemic starting, if there was the early stages of human-to-human transmission, we might be able to go in and detect it and quash the early pandemic with a combination of quarantine, antiviral drugs, and some sort of geographic cordoning, which is another form of quarantine. And the WHO asked the question, could this stop an incipient pandemic? And two modeling groups, one in London and one in Emory and now Seattle, the Longini group, published papers arguing that this was possible. So this is a graph from the London paper on the probability of containment using various measures as a function of the basic reproductive number of the virus at this early stage. And I'll talk about basic reproductive number more, but just to define it for you, basic reproductive number is a measure of the transmissibility of an infection. It's the number of secondary cases that an average infected individual would cause in other people during the whole course of their infection. So it's a function of the virus, it's a function of the biology of the host, and it's a function of the transmission conditions, how crowded people are, et cetera. So they estimated that if this number was above 2, it would be difficult to do containment with any of these types of control, and that if it was below about 1.5, it would be feasible with a number of different possible approaches. if various conditions were met, if it was drug susceptible, if we had enough drugs to treat it, if we could find it very early and stamp it out. And at the time, there was debate about whether these conditions were total pie in the sky or whether they were feasible. Since then, there has been apparent human-to-human transmission in Indonesia, and it's turned out that although probably the human-to-human transmission was very little and suggests a basic reproductive number down in the lower range of this, or even below. Nonetheless, it was extremely hard to get people to comply with antiviral use, to get the antivirals there. There was enough stockpile, mostly because a lot of people wouldn't take it. But it was really an enormous logistical problem, and it took a long time to get it all started. And I think this is not a really scientific point, but I think an interesting point from the policy and sort of international governance perspective. WHO, which is coordinating these responses when a country says we may have a outbreak of a cluster of cases. The WHO has two roles. Their first role is to provide assistance to that country, and it is their policy now to try to do this, to try to bring in very rapid response to these countries to try to stop the initial spread of a virus. Their other role is to communicate to the world what is the risk, are we in a pandemic right now, and basically to provide information. And these are really conflicting roles, particularly in the respect that if your goal is to jump on every possible incipient pandemic, then you have to jump on false positives. It's part of the job. If you don't respond to false positives, you're not doing enough sensitive detection. But if you jump on a lot of false positives, you're going to hurt tourism and trade in that country. You're going to provide people with all sorts of reasons to be concerned about a pandemic because they don't understand that your job is to jump on false positives and also hopefully true positives. So there's a real conflict between these roles, and I think when you read the press releases and the reports from WHO, you see them very much saying, well, we haven't documented that this is human-to-human transmission, which is scientifically correct, it's reassuring, and it's also not the relevant question for whether they should be responding. And sometimes there seems to be some ambiguity there. The last point, which we've spent some time working on, Christina Mills, who is a doctoral student who finished recently in my group, worked on the question of whether a single introduction is the likely scenario for a pandemic, or whether if a virus capable of causing a pandemic arises in birds, whether we would expect to have multiple introductions. So this is what we expect to be able to do to a single introduction, but given the possibilities of failure, you have to compound those if there are multiple introductions. Making overall failure more likely. But then I think the things that will actually be most important when a pandemic next emerges are efforts to slow transmission. And as I mentioned, one of these efforts is a permanent solution, the availability of an effective vaccine in a timely fashion before the epidemic spreads. Because just to remind you, the rate of spread of a pandemic, even in 1918, is on the order of a couple of months through a large population. The US had the first severe outbreaks in September of 1918, and most of the action was over by December, except for those cities, as you'll see in a few minutes, which did very good control measures early on, had a lot of susceptibles around, and then got a smaller wave in the spring. So, but the point is that this all happens quickly, so having vaccines available quickly is important, not just having them available. And then everything else we do, the use of antiviral drugs, the use of social distancing, closing schools, and other things, I think the most informative way to think of it is that all of this is measures to buy time, and this is what we're buying time for. And so the impact of these things can't be considered really in isolation because they're all down payments on getting a vaccine. A year ago, this arithmetic for vaccines was very pessimistic. And David Fedson, who's a retired pharma executive and physician, made the simple calculation that the current global capacity at the time, and it's about the same, it's a little bit bigger now, was about 300 million annual flu vaccines that we could produce with a 45 microgram, that should be microgram, dose of antigen in each one, 15 of each of the 3 types that go in the vaccine. And about a year ago, the NIH did a trial which showed that 2 doses of 90 micrograms were required. So if you do the math, that gives you 75 million people that you could vaccinate with the entire world vaccine supply a year ago. Things have gotten better because there are 2 big companies at least, which GSK, which is reported in the literature, and Sanofi, which is reported by press release, the results of their trials. These are immunogenicity trials. They're showing the production of antibodies. So we don't know how well they'll work in practice, but at least the production of antibodies seems to be possible with 3.8 micrograms of antigen given twice with a special adjuvant. And Sanofi now says even 1.9 micrograms given twice. So if you do that math, you get 300 million, but this is 6 times less antigen even when you give it twice. So then you get about 1.8 billion global doses, or global people who could be immunized if it works. The other good news is that there's evidence of cross-reactivity. H5N1, like all flu A viruses, has diversified in its antigens, so making a vaccine to one strain of H5N1 may or may not be effective against other strains, but there is some evidence that the antibodies generated by one H5N1 strain in this vaccine are effective against a somewhat different virus. But there are, of course, continuing issues, in particular developing countries. I mean, the numbers aren't high enough yet, although they're close to high enough. Developing countries have not been promised a means to get these vaccines, and that's been a controversy in terms of trying to get the viruses out of developing countries where the epidemic might start. And then there's much discussion about production methods. This is all done this is all produced in eggs, and the worst fear is that since eggs come from birds and birds are infected by this virus during a pandemic, the supply of eggs might be interrupted. I'm not sure why a chicken pandemic and a human pandemic would necessarily happen at the same time, but it's a concern, and certainly the technology could be updated. And then there are antiviral drugs, which I'm not going to go through all of this right now, because I'll talk about it in a minute. But concerns obviously are resistance and effectiveness. So far there's really no real evidence that in human cases of avian H5N1 that the drugs do anything except select for resistant viruses, which tells you they're doing something. They are pharmacologically active against the virus, but there's no evidence really that they improve outcomes. And then there's all sorts of other measures also to try to buy time for a vaccine, such as social distancing, closing schools, et cetera, all of which work only as long as they're available. And then there are approaches to mitigation, treatment of secondary infections. Some people think that statins may be promising in trying to reduce the pathogenesis of flu. There are some routine health measures. Pneumococcal disease is one of the secondary infections, which probably even in 1918 was an important part of the morbidity and mortality. So the use of pneumococcal vaccines, which are available already for some age groups, could help, et cetera. So now that was a long introduction, but I think laid out a lot of the issues that I want to talk about on the more research side, and some of the projects that we've been doing recently. And the first one I've already alluded to was the question of how infectious is pandemic flu. And by infectious, I mean the standard basic reproductive number, the number that epidemiologists of infectious disease love to calculate. Some of us do. And I've already defined it for you. And you can see that for various infections, it's very different. One of the reasons smallpox has been eradicated is that it's a relatively low basic reproductive number in the low middle single digit range. SARS was less than that, and it was eradicated without a vaccine. Measles is one of the hardest diseases to eradicate because of its high basic reproductive number. And the numbers for pandemic flu were sort of all over the map, ranging from 1.4 to 20. And so you can imagine that the hopes of blocking transmission of something with 1.4 are much greater than those for blocking something with a number of 20. So again, Christina Mills, as part of her doctoral work, took historical data from 45 US cities and on the rate of exponential increase in the 1918 pandemic, used data from more modern flu to estimate the generation time of the epidemic. And from the growth rate and the generation time, you can arrive at an estimate of this basic reproductive number, which, depending on exactly what assumptions she made, was somewhere between about 1.5 and 3, probably closer to the middle of that range. There's been some discussion, especially among the people who have done the models on containment, where 1.7 is kind of the magic threshold. A lot of them have argued that really the number is closer to 1.8 and not 2.4, but whatever. It's seems to be variable somewhat among American cities, and it's certainly close to that cutoff, if not above it. So what that means is that it gives us a sense of how much we have to chop down transmission to block the continuing spread of the virus. If each person infects 2 people, then you get initially exponential growth. 1 makes 2, 2 make 4, 4 make 8. If you can bring that number down below 1, not to 0, but if on average each person infects 0.9 people, then the disease has to go away in a few generations because each case fails to replace itself. So that sort of cutoff of the basic reproductive number being 1 means that for spread means that if we start out at 3 and we can cut transmission by 2/3, we can stop the spread of the epidemic. If, on the other hand, it was 20, as some people thought, then we would have had to cut down 95% of transmission, which is obviously a much harder thing to do. And so this calculation suggested that based on the most severe pandemic that we know about, we might be able to significantly reduce transmission by a combination of measures, each of which by itself is not that impressive, but which together might do something. And so, again, a number of people have thought about different interventions. The sort of best publicized and most detailed simulations were those by Neil Ferguson and by Ira Longini, again, the London and Seattle groups, where they thought about, within the United States or Great Britain, the attack rate that you would expect, assuming no interventions, assuming that you could treat people and prophylax members of their households, that you could quarantine people within infected households or both. And you see that, for example, neither of these 2 interventions by themselves reduces the pandemic size all that much, but together they do something, and then something more. And then when you add on top of that social distancing measures like school closure and work closure, you can reduce things quite a bit. And also dramatically reduce the peak, which in some sense is as important as the total attack rate, because the peak will tell us how hard the system is being stressed in terms of number of people sick, et cetera. The other implication comes back to something I talked about a few minutes ago, and I'll just make another couple of comments. There's a question of source containment. So it's temporally prior, but another implication of knowing the basic reproductive number is whether it's possible to do source containment. It depends, as I said before, on what the basic reproductive number is, but at least the estimates are that it was within the range in past pandemics that might be feasible to contain. And originally the question was formulated as, can we stop a pandemic with source containment? And Christina Mills, working with Carl Bergstrom and at Seattle and others, reformulated the question as for how long can we delay a pandemic with source containment? Because of course there's going to be another introduction. It might be tomorrow, it might be 30 years from now. But she tried to construct a probabilistic model that takes into account the fact that this risk of a pandemic is fluctuating. It's not that it's just always low and every 30 years or so we have a pandemic. But probably there are periods of high risk and periods of low risk. And when you make some plausible assumptions along those lines, you get the rough estimate that a containment effort might double the time to the next pandemic. So if we think it's going to come in about 5 years, it might give us another 5 years. But it's not going to give us, it's not going to kind of delay it forever. And I think some people have taken this notion to heart, probably through their own ideas, but this notion of kind of delaying and stifling outbreaks rather than stopping a pandemic has become more broadly used, as this New York Times article suggests. So then I want to talk a little bit about the use of drugs for treatment and prophylaxis in a pandemic. This is work with Ted Cohen and Megan Murray. Ted has pet birds, and he hates it when I use this picture, but I love to use it because he had been bitten by a bird that day, which is why he's a little bit swollen and not looking very happy. Bruce Levin always looks happy. So those were my partners in crime with this, and we were essentially interested in how much could antiviral use help in a pandemic. And many of the prior considerations of drug resistance, which of course is on everyone's mind, kind of assumed the problem away on the notion that the probability of resistance emerging is very low, and the probability of resistance spreading is even lower than that. So they had sort of assumed the problem away, and we wanted to take seriously the notion that resistant strains might spread during a pandemic and try to think about what the consequences would be. There's been a rather detailed examination of this paper on the Effect Measure blog, which is much more entertaining than the paper itself. So if you're interested, you may want to go there. So the question we set out to answer was, or to think about was, in the setting of unprecedented antiviral use, so at least dozens of times, if not hundreds of times, more use of antivirals during a pandemic than are ever used in a normal flu season. What would be the consequences for resistance? And then what would that mean for the effectiveness of this strategy? And antivirals are being planned for use in a pandemic in two ways. One is for treatment of sick people. For normal flu, it makes their symptoms shorter. It makes them less infectious to others, somewhat. And it has the risk, because there's a large replicating viral population in an already sick person, it has the risk of providing the conditions for the emergence of resistance. In H5N1, in the case series that's been published, that risk is quite high in the double digit, in the 25% or so range. And there may have been more data since then, but that was the first case series. But in normal flu, it's probably somewhat lower than that. Prophylaxis is the other approach, which means taking someone who may have been exposed within a brief period after they're exposed, giving them antivirals to prevent them from becoming infected. And it does that. It also reduces their severity if they do become infected, and it dramatically reduces their shedding if they become infected. So it's a very good way to reduce transmission if you can get people before they're actually symptomatic. I mentioned before that that's difficult to do for all sorts of reasons in flu, mainly the compressed time scale on which people develop symptoms. But if you could do it, it would be a good way to reduce transmission. And it has a lower risk of resistance emerging during treatment. Than if you give it for treatment. Because the virus population is smaller, probably you'd have fewer viruses around that can become resistant. So it would seem that prophylaxis, from both the efficacy and the resistance perspective, is the better approach. And we wanted to look at that. We did that using a compartmental model, which is the kind of thing I do all day long, some days. These are models that use differential equations to track the status of individuals from being uninfected but susceptible to being infected with a drug-sensitive strain and treated or untreated, or a drug-resistant strain, and then to being recovered. And each of these arrows represents a term in the differential equation, taking people out of this box, and in the other differential equation, putting people into this box. You put all of these together, and by varying the parameters of these, you can understand how the epidemic goes through time under different assumptions. So without going through the 12 or 15 blog pages of explanation of how all of this was done, I'll just jump to some of the conclusions, and you can revisit the assumptions if you're interested. This is a simulated epidemic in a population where neither treatment nor prophylaxis is used. Green is the drug-sensitive infection, red is the drug-resistant infection. There's nothing making the resistant strain appear, so it stays low. And black is the proportion of individuals who are still uninfected at a given time, and that's red on this axis. So a quick epidemic happens, it's over within a few months, and resistance doesn't emerge. If, on the other hand, you use treatment on 30% of the population under a variety of other assumptions, you get a smaller sensitive epidemic, a small resistant epidemic that's roughly coincides with it, and you get, instead of 50% of the, over here, 30% are left susceptible at the end, 30% miss the epidemic. But by using treatment, you reduce transmission enough so that you get only about 50% infected and 50% remain uninfected. And the cumulative proportion of cases that are resistant comes up to about 10%. That's the orange. If you use prophylaxis, on the other hand, again on 30% of contacts of infected people, you again reduce the sensitive epidemic, you reduce the overall size of the epidemic, you cause a resistant epidemic. But interestingly, you actually lead to more drug resistance. So 20% of all the cases are drug resistant instead of 10 under this scenario. And I'll get back to the reason for that in a second. And since each of these promotes drug resistance, if you combine them, you get a lot of drug resistance. By the end, essentially every case has been drug resistant. You delay things by a lot, by a few hundred days. And in fact, you do less to stop the epidemic. In other words, more people have been infected. Sorry, no, you reduce the size of the epidemic again. You reduce the size of the epidemic again. So you have a lot of drug resistance, but it's much delayed. So why is prophylaxis, which I just sang the praises of, doing more harm in terms of resistance than treatment? Well, the reason is that it's actually a better strategy for blocking the drug-sensitive infection. You see there's less drug-sensitive infection here than here. And essentially, the epidemic is a race. There's a lot of firewood out there, a lot of susceptible people. And there are two fires that are starting, the drug-resistant epidemic and the drug-sensitive epidemic. And so if you stop the drug-sensitive epidemic more effectively, then that leaves more susceptible hosts, more firewood in some sense, for the drug-resistant epidemic. And that's a sort of well-known feature of these kinds of models, that when you have a competitive interaction between two strains, anything that blocks the spread of one leads to more spread of the other. So even though prophylaxis doesn't create so many new cases, it doesn't create novel resistance in the person who receives it, it provides a selective advantage at the level of the population. And that's essentially what's happened with most kinds of antibiotic resistance in bacteria. It's very rare to give someone penicillin and give them and make them convert their drug-sensitive infection to a drug-resistant infection. On the other hand, the widespread use of penicillin has selected against those penicillin-sensitive bugs and in favor of resistant ones. The model also suggests that if you can do something to take a virus that starts out with a relatively high basic reproductive number or reproductive number and bring it down by social distancing or other measures, it not only is a good thing in itself, meaning if you don't use any prophylaxis or treatment, you get a lower attack rate, but it also increases the slope of this line, meaning that the additional use of prophylaxis or treatment is more beneficial because it's closer to the brink of not spreading at all. And I'm not going to go into this strange result that the intermediate levels of use are the best. And so one interesting thing is that it turns out that the more you stop transmission by other means, by good things like social distancing, et cetera, you get fewer cases. You get fewer total cases and, in fact, even fewer resistant cases. So that's going from here with a high reproductive number down to here. But the proportion of resistance is the proportion of resistance and actually the number of resistant cases. Sorry. The total size of the epidemic goes down, but the proportion and number of resistant cases goes up. So if you do social distancing and use a lot of drug, you get more resistant cases than if you didn't do social distancing. And the reason for that is kind of hard to explain and to understand, but essentially it's that if you do the social distancing and you slow down transmission, it allows more time for the resistant strain to gain an advantage over the sensitive strain. Whereas if you don't do that, then the sensitive strain, which is common at the beginning, uses up most of the population before the resistant strain can spread effectively. So I think there's nothing bad about a resistant case except that it's a case in some sense. So this is not saying you shouldn't use antivirals or that you shouldn't use other measures to slow things down. But it's saying that the more effectively you slow things down, the more you're going to allow the resistant cases to spread while still bringing down the overall size of the epidemic. So the consequence or the conclusions of this study was that resistance is likely to emerge and spread if there's heavy antiviral pressure. There are a lot of assumptions that I didn't talk about, and the main ones that are required to get that result are that at least some resistant strains, even 1 in 10 or 50,000, if a very small proportion of resistant strains are capable of spreading effectively with a modest handicap compared to their sensitive competitors, then it's likely under heavy use that there will be significant spread of the resistant strain. On the other hand, if every single resistant strain is unable to spread, then, or is very, very badly handicapped in spread, then none of this will happen. You just won't get much spread at all. But essentially what people have imagined is, well, most resistant strains we've seen to date have been very badly handicapped, and so therefore we can just imagine that all of them will be. But the number of new strains coming up in a pandemic, new resistant strains, is much bigger than we're accustomed to because there's more selection pressure. So imagining that they'll all be so badly handicapped, I think is not sensible. But on the other hand, so resistance is likely to be a problem with widespread use. On the other hand, when we go back to the overall impact, we explored this under a much wider range of conditions, but I'm not going to go to all of those. Even in the case where everything is resistant, you still get some reduction in the total size of the epidemic from about 70% to about 60%. And most importantly, you buy yourself a couple hundred days, which in the setting of a pandemic is a long time, especially if there's something at the end of those couple hundred days like a vaccine being produced. So the situations under which resistance appears are, even in the most severe ones, there's some gain in the total size of the pandemic, and there's a delay which might allow you to bring in other measures that could be useful. So I think that's all I want to say about drug resistance, and then I'll conclude just briefly talking about a historical study that I did with two colleagues, Richard Hatchett and Carter Metcher, where we looked at the impact of non-pharmaceutical interventions in 1918. So social distancing, school closure, et cetera. You'll actually see a list in a second. As you see, I like to show pictures of people I work with. They both worked in the White House on the team that was developing a pandemic flu plan. And as you might imagine, I was a little skeptical about working with people in a government with such a reputation for the support of science that it likes. And I can only say that those fears were in no sense realized. It turned out you sort of fear that people who have something at stake in a scientific investigation will try to bias the results, but you hope that people who have something at stake will be so concerned about getting the right answer that they'll try to get the right answer. And my impression of these two collaborators was very much that they really wanted to know what was true, and it was a delightful experience. So this was, and it turns out what I'll talk about, there were two other groups doing exactly the same thing with various different techniques, and all of them came to exactly the same results. Two of them were published, this one and the London group together, and then a Michigan study came out just afterwards, really saying all the same things. And so the question is, did non-pharmaceutical interventions work? There was a lot of variation between American cities in their epidemic curves. Philadelphia had a very early, very severe, and very brief pandemic with excess deaths at 250 per 100,000 at their peak. St. Louis, on the other hand, did much better. They had a much flatter epidemic. It took longer, but it was flatter. There was a second peak, a small one. And it turns out that Philadelphia did all sorts of things, did very little to try to control spread, while St. Louis did a lot to try to control spread. And the question is this causal, or is this just two nice examples that happen to fit a hypothesis? So we made a comparison across 17 US cities, comparing the timing of intervention, the timing when they put into place various interventions to control spread, with the outcome. And the main outcome we looked at, for reasons I will happily talk about afterwards if you want, is the peak excess pneumonia and influenza mortality. These were the interventions we considered: making flu reportable, declaring an emergency, household quarantines and placards in the houses of people who were sick, dance hall and theater closure, school and church closure, etc. So we counted them each as one intervention. We didn't make a priori judgments about good or bad ones. We just considered them each. And what we found was that when you compare the number of interventions by a relatively early phase in the pandemic, the time at which 20 per 100,000 excess deaths had occurred, so that was quite early in the pandemic, against the peak mortality in these cities, you see that with admittedly a lot of noise, there is a statistically significant and somewhat impressive correlation between doing lots of interventions early and having a lower peak. So that St. Louis and Philadelphia comparison seems to be real when you expand to 17 cities. This is another way of looking at it. This is the number of people who had died at the time when the third or fifth intervention was put into place versus the peak. So it's really just flipping it, and you see again an increasing relationship now, meaning the later you waited, the more people had died before you did the intervention, the higher the peak. I don't know what that backward thing meant. And then if you just chop the cities in half for those that had 4 or more measures in place before 20 per 100,000 excess deaths versus 3 or less, and you compare the peaks, this is the difference, and it's statistically different. Same if you look at the number of measures in place by 30 per 100,000 excess deaths. And then if you look at some of the individual measures, like closing schools, churches, theaters, and public gatherings, you get similar relationships, some of them significant, some of them not, in this sample of 17. These were the ones that were done commonly, and as such, I wouldn't say that they are necessarily causal, that just because schools is significant and public gatherings is not, that schools is meaningful. There's lots of collinearity among these, and there were 17 data points. So the point is that any individual intervention tells roughly the same story as the overall numbers. And I think I have talked for longer than I wanted because I'd much rather hear what David has to say. So instead of telling you all of the sensitivity analyses and ways we tried to be skeptical of these results, I'll just throw skepticism to the wind and hope that you will do the same. And just mention that I think some of the open questions in this field are, we still don't really understand where transmission happens even in normal flu, much less in pandemics. And then there are a number of logistical and technical questions like, will the antivirals work, the ones that we have or new ones? Can vaccines be plentiful enough, distributed enough to people who can and can't afford them, and effective enough against a wide range of strains? And so far, that's an area where there's some good news. And then how will society adapt? So I will stop there and turn it over.
I've heard a lot of presentations about flu pandemics, and you really can't do better than the one we just heard right now. And the paper that Marc has been talking about on antiviral resistance is a model for model papers, too. It's really a wonderful paper with the advantage that it produces some counterintuitive results. It's always nice to have counterintuitive results because otherwise you don't feel like you've learned anything. In listening to Marc, he didn't leave me with a lot of things to say that would be new, but he did leave you with a couple of questions at the end, which he went over very rapidly. When I graduated medical school, I knew just about everything there was to know about flu. This was in the 1960s. In fact, my public health preceptor was a guy by the name of Ed Kilborn, who was Mr. Flu at the time, and he taught us everything there was to know about flu. And the fact that I forgot it promptly in about 3 weeks afterwards doesn't really make any difference because almost all of it was wrong, and there wasn't really very much of it either. Mike Osterholm, who some of you may remember as the first Bicknell lecture a couple of years ago, told me once that he knew much more about flu 20 years ago than he does now. And that's true, actually. Every time a paper comes out, we find out that something that we knew about flu is wrong. So I just have a couple of minutes, so instead of providing answers for you, I think I'll just pick up where Marc left off and give you a list of the top 10 things, the top 5 things I wish I knew about flu now that neither I nor anybody else seems to know about flu. So we're about ready to come into flu season. I hope you'll all get your flu shots, even though, in fact, for people my age, it isn't clear it does any good. I'm going to get one anyway because I believe in magical thinking. But the fact that flu season is coming up is itself sort of a mystery, which is everybody knows that flu is seasonal, right? But why is it seasonal? Nobody knows actually why flu is seasonal. And so that's just number one of the things that everybody thought we knew that it turns out we really don't know. So number two of things that we thought we knew that we really don't know, and which turn out to be pretty important for things like social distancing, which is how is flu spread from person to person? Almost everybody assumes that we know the answer to that question. And maybe in a general sense we know the answer to that question. But once you get past the surface veneer, we don't know. So for example, if it's spread by breathing out flu virus on other people, how big are the particles that that flu virus is attached to? If they're very tiny, they may remain suspended in the air for 24 or 48 hours. If, as we have assumed, and as I learned, and as we've been teaching people, and as which CDC I think still has on their website, they're very large droplets, they'll fall out within a few meters. And moreover, certain things like wearing masks, might very well help you. Certainly, masks is probably a good thing if you're sick, because you won't make other people sick. But the question is, will wearing a mask, including these N95 respirators, protect you from getting sick from somebody else? Also, all this stuff about, the armrest on the airplane and the doorknob and the pencil that you picked up that somebody just coughed or sneezed on, the so-called fomites is a way to transmit flu from one person to another. It is true, in fact, that flu virus will remain keep its ability to replicate on a hard surface for a very long time, 24 to 48 hours or even longer. It'll stay in fresh water, replicable for sometimes up to 14 days. But there is at least some evidence, although very scant evidence, that once the flu gets on your hand, it may only remain replicable for about 5 minutes. All right. So we really don't know what the role of flu on inanimate objects like doorknobs is in transmitting flu from person to person. So it would be very nice to know of the different ways that flu might be transmitted from person to person. What's the main way that we have to worry about? Or are they all sort of equal, or is one much worse than the other and some non-existent at all? What else would I like to know? Let's take the H5N1 potential pandemic strain or subtype. It's really nasty. I mean, it's got a case fatality ratio of currently over 60%, and in Indonesia it's over 80%. That means in Indonesia, which has more cases than any other country in the world, 8 out of 10 of people who are diagnosed with avian influenza die. The trouble is, every time somebody's gone out to look for these mild and apparent infections out in the real world by doing seroprevalence surveys, they don't find any. I mean, they're not there by any way that we've been able to figure out. So that's kind of worrisome, I would say, because if that's really the case fatality ratio, then probably the non-pharmaceutical intervention, which you didn't mention, is to sit down, put your head between your knees, and kiss your ass goodbye, because that's where we would be. One of the things we see in places where people get this, and of course it's said all the time that the way you get this is from poultry, right? That's because there's poultry all over the place, and every time there's a case, there's almost certainly poultry within 500 meters, half a kilometer, 2 kilometers. So the Indonesian government is really fond of saying, oh yes, we haven't been able to find that this person who just died from avian influenza actually handled sick birds, but there was a sick bird in the next block or 2 blocks away or 5 blocks away. It'd be really nice to know several things about this. Are there other reservoirs and potentially vectors? So we know it'll infect dogs and cats and ferrets and mice. Are there other animals? A paper just came out a couple of days ago that says that this virus can infect starlings, sparrows, and pigeons, although it's not clear that they can transmit it, intraspecies. So are there other things? Maybe bats, for example. Are bats a possible reservoir? We've done almost no looking for where this virus really is out there in the real world. The other thing that you see is, you'll find a case in a village in Indonesia where everybody keeps birds. It's poultry all over the place. Everybody handles birds. A 23-year-old male handles birds that are sick and gets avian influenza and dies. Well, what about all the other hundreds of people in the thing? Nothing happened to them. In fact, there's no evidence that any of them are infected if you do a seroprevalence follow-up investigation. So why do only some people get sick and not others? Because there's so much exposure out there. So that's another one of the mysteries that we just don't know. And are all the people who are getting sick actually getting sick from poultry? Can you get sick from eating poultry? or being exposed through the gastrointestinal tract. Well, certainly you can inactivate this virus by cooking it, right? You can inactivate salmonella by cooking it too, right? You know how many salmonella cases we have in this country every year. So it's, people who are exposed to salmonella when they're preparing the food, or food is not properly prepared or undercooked and so on. You're going to hear, don't worry about this. The FDA and the USDA particularly says properly cooked food will not transmit avian influenza. Properly cooked food will not transmit salmonella either. Just a couple of more questions and I'll wrap it up. I actually have just a long list of questions, but these are just a few. Mark talked about the vaccine trials. And, do the vaccines work or not? Well, the trouble, not the trouble is, the good thing is we don't know whether the vaccine works is because we don't have a pandemic of H5N1, and therefore we can't see whether the vaccine protects people against H5N1. So that's good. The bad thing is, how do you tell whether the vaccine works? Well, we measure neutralizing antibodies in the blood of people who've received it. We don't really know how much protection that affords. We assume, actually, at the titers that are being produced, if they're comparable to what we see in seasonal influenza, that they'll protect people, but we really don't know that. I'll leave the list of questions there. I will just mention one more thing, that everybody knows that microbes don't respect political borders, but what very few people realize is that the way we govern our system of international governance for disease control on this globe does presuppose, in fact, that microbes do respect borders. And the World Health Organization, up until July 17th of this year, really had no ability to get any information about any epidemiologic information, legal ability, to get any epidemiologic information except from a member country. And it had no authority to, and still has no authority, to go inside the borders of a member country and tell them to do anything, even though everybody knows that what happens inside the borders of a country can affect everybody else outside the borders. Our system of international relations, it still remains an anarchic system. And when I say anarchic, I don't mean confused and chaotic. What I mean is that there is no government above sovereign nations, right? And if there's no government above sovereign nations, and national sovereignty is the linchpin of the international system, it becomes very difficult to devise a germ governance system for the globe under those conditions. Conditions that go back to the end of the 30 Years' War in 1648 with the Peace of Westphalia. So we are really operating with an outmoded political structure trying to deal with a problem that knows no borders, but which depends upon borders for almost everything that it does. So I'll just leave it at that, and I'll let Mark come up and answer questions, because all I have is questions, I don't have answers.
So if you end up with a vaccine, I assume there won't be enough vaccine immediately for everybody. Who would you give it to? You give it to the men's health leadership? Because
They have great, vigorous immune systems. It's a big question, and it's not obvious what the right answer is. The basic principle, I think, is that there are two reasonable approaches. One is to try to give it to the people most likely to die if they get infected, times perhaps the likelihood that the vaccine will work in them. And the other is to try to block transmission with the vaccine. And if you have a very tiny amount of vaccine, then you probably want to try to direct it where it will directly save lives, because you're not going to make a big dent in transmission. And you may as well save lives. Which means, we don't know for a pandemic vaccine who it'll work in. We know in the normal vaccines, normal flu, that it works for people. It works for people under 65, and then depending on who you believe, it does or doesn't work for people over 65, and it's a raging controversy now. It probably works a little bit for some people over 65, but the question is whether it works much. In pandemics, it may be a different story because, I mean, probably those same people will not get as much benefit from the vaccine, but are there other groups that are at more or less benefit from it? Also, the pattern of who gets sick is different in pandemics, and it was different in 1918 from what it was in 57 and 68. It was more weighted towards the middle age groups in 18 than it was in 57 and 68, although it was in all cases elevated. So in some sense, I think the answer is first we need data about in real time as the pandemic is happening to see what the pattern is like this time. I don't think it makes sense to have an age group or a target group before. It makes sense to have principles before, and then we need data. The second thing is I think it depends on how much vaccine. In the very early stages, if 40-year-olds are at the highest risk of dying and they seem to be able to respond to the vaccine, they would be the ones I would give it to. And then if there's enough vaccine for 10 or 20 or 30% of the population, then you start thinking seriously about how to block transmission. And one of the things that I'm working on now is to try to figure out, with the limited information as data come in a pandemic or a new emerging disease, how do you make the best guess at who could affect transmission the most? And we think we have some ideas, but we're still working on it. So that's an open question. Yeah. Yeah.
Is there anything known or interesting out there that maybe isolated community groups in China are people that had different levels of resistance or different?
You mean for H5N1 or in general? Not really. There are some old studies using radioimmunoassays, which I gather are not as believable as the modern technologies, which are themselves not very believable for antibodies. So take them with a grain of salt. There are some old studies showing that in rural China, people have antibodies, tens of percents of people in some parts of rural China have antibodies to various flus that none of us have ever seen, or most of us have never seen. And so whether those are real antibodies and whether they're effective is an open question, and whether they ever had a severe disease from those people, those is an open question. So there probably are, but if they've been handling birds, there probably are some exposures to weird viruses that just don't make people sick enough or enough people sick to call attention. So there may be some immunity out there. Whether it's of any use or not is unclear. In terms of genetic resistance, there's been a lot of speculation that the answer to David's question is the reason that poor guy got sick and everyone else didn't is he had some genetic susceptibility. There's no evidence for that. And another study that we did, a really small study that Jenny did as part of her PhD thesis, was to look at the evidence of clustering by families. So people have said when you look at family clusters of H5N1 infections, they tend to be in all blood relatives rather than in husband and wife within a household. So if it's in a household cluster, it tends to be blood relatives. And she just did the sort of combinatorics of, with different household structures, how often by chance alone would you expect to see only blood relatives infected? And the answer is about the same frequency as has been seen. It's about 87% or something of the cases have been in only blood relatives. And for sort of plausible household sizes, we don't know the real household sizes, but plausible ones, if there's no genetic differences, that's how much you would expect. So there's no direct evidence.
You showed in one of your initial slides the expression resistant and non-resistant strains. Does that affect the mortality of the population?
Drug resistance, you mean? No one knows yet. Of the people, the first case series that came out, and I haven't followed all the case series, but the first one was in the New England Journal. There were 8 people who were treated with oseltamivir, of whom 2 of them developed resistant infections or detectable resistant virus, and I believe both of those died. Maybe somebody else remembers, but I think both of those died. So it is, well, they might have died even if they hadn't gotten the resistant one later on. Basically, if you go in the lab and try to isolate a resistant virus to the neuraminidase inhibitors, they're really unhappy viruses. They don't replicate well. They don't do all the things viruses want to do. Less true for the other class of drugs, the M2 inhibitors, but for the neuraminidase, the average resistant bug is a very unhappy bug. So if I had to guess, I would say yes, they would probably cause less mortality. But the one that's able to spread is going to be the one that's the least unhappy of all the unhappy bugs. And if it starts to spread, then I would withdraw my bet.